I think that he might.
All right, let me figure out how to mute everybody. Remember this. Oh, here we go. I don't seem to be able to mute everyone like I was last week. Just give me a moment. Okay, I see Daphne is there. Very happy message from Dr. Ellis Rochelson there. Okay. All right, let me share my screen. Okay, can everybody hear me okay? Yeah?
Yes, we can hear you.
Yeah. Okay, great. I heard the voice of Grace Hong, I believe.
Yes.
Okay, so I just ask everybody to mute themselves. I seem unable to do that, and I have a feeling this will prove a problem later in this meeting, but there you go. Okay, so abbreviated EP conference today. And I thought we would start by reviewing Class 1A agents. And so you'll recall that the Class 1A agents are quinidine, procainamide, and disopyramide. And they block rapid sodium channel, slowing the upstroke of the action potential. And they also prolong the potassium channel duration of the action potential and therefore prolong refractoriness. So they have predominantly sodium channel blocking agent activity, but they also block the potassium channel. And you can see in this little wonderful drawing I've made of the action potential, which is a knockoff of Dr. Walsh's old textbook, that it has an effect both on depolarization and repolarization. Again, if everybody could kindly quiet their audio. Just trying to, doesn't seem I know how to, let's see, can I mute all? No. All right, sorry guys. Okay, let's move on. So quinidine is absorbed, this is the first of the three agents. It's absorbed 80 to 90% from the GI tract. It's eliminated via the liver, and it has a fairly short half-life of 5 to 8 hours. And again, as all 1A activity is, it's both a sodium channel blocker predominantly, but also blocks potassium channels. And it has a number of hemodynamic effects. It blocks alpha adrenergic receptors, which results in peripheral vasodilation, which causes a reflex tachycardia. And quinidine is also a vagolytic, and it may enhance AV conduction. And these are the two reasons why whenever starting quinidine on someone, you want to at least consider starting an AV nodal blocking agent, particularly when you're treating an atrial arrhythmia, because quinidine may actually make it easier to conduct and could potentially result in more hemodynamic embarrassment from an atrial arrhythmia. And so you want to be careful with this agent, and we'll talk about why I'm mentioning this drug at all, since probably no one on this call has ever used it with the possible exception of Dr. Arnon and myself. There is no direct negative inotropy of significance with this agent, which is a nice feature. And what is it used for? Well, traditionally, it's been used for atrial and ventricular arrhythmias. It used to be used fairly commonly in accessory pathway-mediated tachycardia, such as orthodromic reentry. It was also apparently used fairly commonly for AVNRT. But I would say that because of all the side effects of this agent, which we'll review in a moment, it really is almost never used for any of those indications today, because we have other agents that are better at treating these problems and don't cause all of the side effects. However, the reason that I'm mentioning quinidine is twofold. One, because it seems to come up every few years in terms of its side effects on the boards, but also because it has developed a new use specifically for patients with Brugada syndrome who have atrial tachycardias, such as atrial fibrillation or flutter. You may be aware that although Brugada patients are predominantly known for the problem of having ventricular arrhythmias and sudden cardiac death, they also, in not so rare cases, can have atrial arrhythmias. And it's been shown that quinidine is a safe agent and fairly effective at treating these arrhythmias. And this can be a real problem because, as you probably are aware, there is no known treatment for Brugada syndrome at this time. And so most of our Brugada patients who have had a cardiac arrest or have a very, very strong family history will implant a defibrillator in. And so if they have atrial tachycardias and they start to conduct rapidly, they could get shocked inappropriately. And so I myself follow a patient who is on quinidine for this indication and reason. Now, side effects are the reason we don't use this agent except rarely, because almost 50% of patients can develop them. And the most common are GI, specifically diarrhea. It is as you would imagine, with effects on both sodium and potassium channels, it has a real possibility of being proarrhythmic. So one would not start this agent as an outpatient, and you would have to follow a patient like this with monitoring of different sorts. And then synchonism is common in quinidine, and synchonism is a term used to denote all of these neurological issues such as tinnitus, visual blurriness, and hearing disturbances. And tinnitus is the one thing, at least when I took my boards 23 years ago, that was the thing that was asked very commonly. Even though 23 years ago we never used quinidine, but still tinnitus was apparently is a very, very common side effect of quinidine. So, okay, it interacts with warfarin, potentiating its effect, so you have to reduce warfarin dose when you're on quinidine. It increases digoxin levels, and quinidine levels are lowered when you're giving the following agents simultaneously, such as phenobarbital, rifampin, and phenytoin through cytochrome P450 mechanism. And levels are higher when you're giving amiodarone concomitantly as well. Now let's move on to procainamide, which is a drug that is more commonly used and is growing in its popularity over time. Again, when it's given orally, which is rare these days, it's very well absorbed, 70 to 90% from the GI tract. And it's important to remember that procainamide is metabolized in the liver to NAPA, which is actually a class 3 metabolite. This is something Dr. Walsh used to always like to emphasize. And so, and NAPA is excreted by the kidneys. So you actually have to have both liver and kidney function that is normal to be on procainamide, or at least the dose has to be adjusted accordingly. And you have to remember that NAPA is an important metabolite, which is a class 3 agent and can prolong the QT interval. And so when measuring procainamide levels, you would want to measure the procainamide level as well as the NAPA level. The half-life is short, it's 3 to 5 hours. And again, as I mentioned a moment ago, it's both a sodium channel blocking agent as well as a potassium channel blocker. Procainamide has a number of hemodynamic effects. The most profound one and the most important one is that it blocks alpha adrenergic receptors, resulting in peripheral vasodilation and a reflex tachycardia. And I would say it's fairly common to become hypotensive during infusion of procainamide. And for this reason, one should slow the infusion rate if you're getting vasodilation, or potentially even add some fluid as a bolus. I often, when giving procainamide IV, will recommend that volume is available, such as saline or Ringer's, because it's not uncommon that you have to do a little bit of fluid resuscitation. But the important point is it's not a negative inotrope, except at toxic levels. And in a paper that I reviewed on my podcast about 2 years ago, written by Lizzie DeWitt, she did I think it was a patch clamp study in which she studied the effect of these various different IV antiarrhythmic agents on myocardial performance. And she demonstrated actually very nicely that procainamide, interestingly, was the least negative inotropic effects of all the IV antiarrhythmic agents, which is not exactly intuitive, since I think most people traditionally have thought of amiodarone as being the one that has the least hemodynamic impact, but in actuality, it had the worst. Amiodarone was the most potent negative inotrope of all of the IV antiarrhythmic agents. And one of the things I learned from Lizzie in speaking with her is that the way that they avoid the hypotension of procainamide is to give it in smaller aliquots. So they rarely give more than 5 per kilo as initial dose. And if they don't see effect, they give another 5 per kilo. And they found that by doing this, they are not seeing hypotension as often as is often reported in the literature. Okay. Procainamide is used for both atrial and ventricular arrhythmias. It's particularly good for atrial reentry. It often prolongs the cycle length of tachycardia. In ORT, it may actually terminate ORT because it has very potent effects on accessory pathway conduction. And it's very effective for ventricular arrhythmias as well. So there really are very few things that procainamide is not pretty good at. I would say that it is the drug of choice when treating atrial arrhythmias with rapid conduction. And last week we reviewed an example of a patient who had pre-excited atrial fibrillation. And although we would all agree that, treating that with cardioversion is probably the right thing to do, procainamide is a good second choice, or even first. Side effects, again, are hypotension with IV infusion. It can cause the GI side effects such as nausea and vomiting in about 25% of patients. When you're giving it chronically as an oral agent, which is rarely done today, it can cause agranulocytosis. So one has to monitor the CBC when putting somebody on this agent. And this problem of a lupus-like syndrome was seen pretty commonly in patients given procainamide. And the longer the patient was on it, the more common that this would occur. And usually, and they would get all the symptoms, the malar rash and itis and things like this. And the symptoms would usually resolve within a few weeks of discontinuation of the drug. And the other thing I would mention about proc, and one of the reasons we don't use it in addition to this issue of lupus, is that it only comes orally in a very large dose. So it has to be given Q6 if it's the short-acting or the regular proc, and the long-acting procan-bid is what it's called, I think standing for BID, comes, I think the smallest dose is 1,000 milligrams. So basically one needs to be an adult-sized patient to take it orally. But again, most of the time we're using procainamide as an IV agent, not as a chronic oral agent any longer. It can interact with amiodarone and trimethoprim, and the drug levels of both would be increased if you gave proc with it. Probably wouldn't recommend either. And drug levels are decreased with alcohol consumption. All right, and just for completeness sake, since we're discussing all the 1A agents, disopyramide is lumped into that category. It's chemically dissimilar to quinidine and procainamide, but since it has similar electrophysiologic effects, Vaughan Williams decided to put it in the same categorization. It's really not used clinically almost ever anymore. It's an extremely potent negative inotrope, and so every once in a while, you'll rarely see a hypertrophic cardiomyopathy patient in whom disopyramide is used. As you know, most of the time, if we're treating outflow gradients with medication, which as you know is not particularly effective, but some have better experience than others. Beta blockers or calcium channel blockers are used, but it turns out disopyramide is quite effective at this. And every once in a rare while, you'll see an older patient who maybe 20 years ago was started on this agent and has remained on it for many years. The side effect of disopyramide is it has a lot of anticholinergic effect, causes dry mouth, eyes, and the throat in 40%, and it can precipitate closed angle glaucoma. So want to be careful with your many glaucoma patients. Okay, so we're going to move on to the EP potpourri portion of today's talk. And I want to give a special thanks to Lieutenant Colonel Ryan Flanagan, who is a physician in the Medical Corps in the U.S. Army and Tripler Army Base in Hawaii, who was kind enough to share with me many interesting EKGs, some of which will make their way today into the talk and to future talks. So thank you, Lieutenant Colonel Flanagan. Okay, this is a patient with pulmonary atresia who had a central shunt and atrial septectomy as his initial palliation. And he went for ablation with a hack of an EP doctor last week. And the question is, what is going on? After an ablation is performed, it's not uncommon that we're going to check telemetry a lot. And I just turned on telemetry around 12:30 this weekend on one of the 2 days, and I saw this and I was like, what the hell's going on? So let me ask Dr. Uzoma Obiaka of Upper East Side of Manhattan what she thinks is going on here.
Yes, Dr. Pass. So, good morning, Dr. Pass. Looking through the tracing, it looks like we're intermittently pacing, but not capturing in some spots. So, let me see. PQRS. And then in some beats, we're having a couple of PACs that seem to be aberrantly conducted.
Mm-hmm.
So it's like a mix, really. So a couple of sinus looking bits, and then here and there some PACs that are aberrantly conducted, and then
I agree with
it looks like we're trying to pace, but we're not, because I see like the pacing artifact, but it looks like we're not capturing all the,
right.
We're not capturing effectively.
Is there anything else wrong with the pacing? I agree with you that we are not capturing. That is one serious problem of the pacing here. So that
It seems to be inappropriately. It seems to be inappropriately pacing as well. Like, I'm not sure if that's like an undersensing or oversensing, but like the inappropriate pacing spikes almost.
Right. So this is first of all, if we just look at the rhythm and try to, in our own mind's eye, not look at the pacing spikes, I think it's fair to say the patient is in atrial bigeminy, right? So looks like a sinus beat and an APC, which is conducting aberrantly, a sinus beat and an APC conducting aberrantly, a sinus beat and an APC conducting aberrantly. So this is so-called atrial bigeminy, or single PACs following every sinus beat. But then we have this pacing. This is why I made a feverish text message to Dr. Kung, who was not aware that this was going on, so bears no responsibility for this. But I asked, what the hell's going on? And to make a long story short, through the temporary pacing wires, the heart rate was falling intermittently into the 70s and 60s. And so the nurse had been told to plug in the pacemaker and pace at 100. And as you can see, it's pacing without capturing, and it also is not sensing at all, right? This should not be pacing. If there was an atrial sensed event here, for example, this is a rate of about 160, 170. It certainly is not programmed to pace at 170. It should have sensed this P wave and not paced here, just as it should not have paced here when there's a P wave right there. So this is both undersensing and non-capture of this wire. And we've known for a while that this wire does not sense well, but we now know it wasn't capturing. And actually, Grace increased the output on the device quickly, ran upstairs, and was able to pace 1-to-1 at 100 beats per minute. So now the next question is, so that was obviously bad, and we're going to need to do a little bit of education for the nurse who just sort of blindly plugged this in. And had I not, what's the downside of this? Well, the downside is that you could induce an atrial arrhythmia, right? You can induce IART by pacing inappropriately into the atrium. Probably the only reason we didn't is because we weren't capturing. So if the output had been higher, and we were capturing, we might have induced some form of atrial flutter. So this was potentially dangerous. Now, for me, as the ablator, this was obviously disappointing to see PACs. But in fact, when we looked at a 12 lead of this ectopy is not the EAT that we ablated. This is a completely different focus. And in fact, with a modest dose of sotalol, the patient has been predominantly in sinus rhythm, a dose I might add that would never have controlled the EAT in this 6-month-old that we ablated. So that was another proof that this is a different focus. And unfortunately, when we did the ablation, this ectopy was not present in the cath lab, and so was no way to map it or ablate this. But it doesn't really matter because, as I mentioned, on a modest dose of sotalol, we were easily able to put the patient into sinus rhythm, and that was nice since we have tried 6 different agents in various combinations unsuccessfully. So this overall was a success. All right. This is a nice tracing from Dr. Flanagan. This is a 9-year-old with palpitations for electrophysiology study and ablation. And my question to the audience is, where do you believe the accessory pathway is located based on the pattern of this ECG? I would like to ask, let's ask Dr. Neha Lawalia. Are you there, Neha?
I am. Morning, Dr. Park.
Good morning, Neha. How are you?
Good. So for in the 12 lead, you can see it is an accessory pathway because it's short PR and a delta wave. And the way that you can tell where the pathway is that I've used the Aruda algorithm, which I don't remember on top of my head, but let me see.
Well, why don't I go over it? I agree that you would
Right.
want an algorithm, and the Aruda one is, which is sometimes referred to as the Oklahoma map, is the one that's most commonly used, probably because it's very accurate or fairly accurate and is easy to use. So I'm gonna do it here. So, and this is important because when you are taking care of patients that have WPW, the decision to ablate somebody and when to ablate them can be affected by where the accessory pathway is located. For example, if you knew a pathway was remote from the AV node, for example, a left-sided pathway, and if you knew that the patient was having a lot of tachycardia, you could consider ablating that patient at a fairly young age, maybe even as young as 3 or 4 years of age. However, if the pattern suggested that the pathway was sitting in the anterior septal region, which, as you recall, is where the AV node is located, then you would be a lot less inclined to be excited about ablating a small. Can Kasarova please lower your, mute yourself? Thank you very much.
Рахим,
Hello, please mute yourself. Thank you. Okay.
я все настроил.
Oh boy. Sorry, guys. Okay. All right. So let me show you how one would use this. Anybody know how to mute people?
Сергей, хотите участвовать в вебинаре?
Excuse me, Kasarova, please mute your phone. Okay. Okay, so this is the Aruda algorithm that Dr. Lawalia referenced, and it's very simple, and let's look at this EKG that Dr. Flanagan has given to us. First, in step 1, we look at lead 1 to see if the delta wave is isoelectric or negative, or if in V1, R is greater than S. And so when we look at lead 1 on this ECG, we see that, that actually the delta wave is positive. It's going upright, so this is rejected. And in V1, we see that the S wave is much larger than the R wave. And so we've proven then that in reference to question 1, no, this is neither is true. So this removes it from being on the left side. We then go to step 2 on the Aruda map, and we look at lead 2, and if the lead 2 delta wave is negative, then we see that it often is a sign that it's near the coronary sinus or even the middle cardiac vein. And the middle cardiac vein is an area very difficult to ablate accessory pathways, associated with a high recurrence rate, and it's difficult to get a catheter into. So you would be disinclined if it mapped to the middle cardiac vein to try a small child with this pattern. But in fact, our delta wave is upright in lead 2, so we would reject this and say that this is not true either. Now in step 3, we look at V1 to look at whether it's isoelectric or negative. And here I think we would say it could be potentially isoelectric. It's hard to say. So that would suggest that it's, so I'd say yes on this one. And now we're looking at AVF. And I think we would agree that the delta wave is positive in AVF. And so then to figure out whether it's anterior or mid-septal, we look at the QRS axis. And if the QRS axis is greater than 0 degrees, as it is in this case, because we have upright QRS and 1 in F, it would put it in the anterior septal region. And you see the sensitivity, specificity, and positive predictive value are very high if you have this pattern. And so this patient, we can predict based on this appearance of the ECG using the Aruda map that Dr. Lawalia suggested we look at, that this is an anterior septal accessory pathway. So if I saw this patient, I would make the decision about whether to ablate this patient based on how bad the symptoms are and also how large the patient is. Now, it turns out there's not really very much evidence that being larger definitely improves the success rate or the safety, but I think it stands to reason that two structures are going to be farther apart if the patient and the heart are larger, potentially. At least one would think that's the case. So let's see what happened here. Let me get through here. So this was the tracing that Lieutenant Colonel Flanagan was kind enough to share with me in this patient after they were ablated. And why don't I ask Dr. Kong what she thinks is going on here. This was apparently obtained in the post-cath period in the recovery room.
So I can see that the delta wave is no longer seen, but I also don't see a P wave before each QRS. And actually, I think I see a retrograde P wave after the QRS, especially in that rhythm strip that we have in the very bottom in lead 2. And I thought it was retrograde, but at the very end, there is potentially signs that the A to A and the V to V are consistent, but not speaking to each other. So it looks like we may have caused some heart block. If the patient is still on the table, we'd probably do some studies to look at the AV node. Since this is immediately after the ablation, there's a chance that this is just transient.
I see. All right. Well, I agree with most of what you said, Dr. Kong, as I usually do, because you're very smart. What we're seeing here, I agree. These look like retrograde P waves, right? And what we're actually seeing here is junctional rhythm, right? You said there's no P wave before every QRS, and it appears as if there may be a retrograde P wave after. Please, if you could mute yourself. Let me just see if I can just find whoever is on here. Excuse me, I apologize. Just do this quickly. Seems I think I got everybody. Okay, if I've muted you, Grace, I apologize.
Hi, Dr. Bartikin, this is Diana. I'm going to be on the cut with you today.
Okay, yes. Diana Torpoco, please mute your phone. Thank you. Okay, so post-ablation. So again, what we have here is junctional rhythm with one-to-one VA conduction. But then look at this beat at the end here, Grace. What do you think could possibly be happening here?
Oh, yeah. So if that's junctional, maybe the P wave.
But what's happening here?
I think that P is not conducted, but it did come in before the junctional rhythm came in.
Could be. And what do you think about this beat to the right of it, though?
You're right. That one is probably a conducted P wave.
And what do you think about this complex?
It looks aberrant. And
Well,
I don't know if, right,
remember this patient had WPW.
PW. And
Had
if
an
this
ablation.
is what his EKG looked like before, he still might have, his pathway might still be there.
Right. So
Mhm.
the point is that, when you do a WPW ablation near the AV node, you risk injury to the AV node and the his Purkinje system. And so basically, this is a very typical EKG in somebody who had an ablation a little too close to the AV node and the His, because what we're seeing here is junctional acceleration, which presumably is due to the fact that the RF catheter either touched or burned partially the His bundle, causing junctional acceleration. The other interesting observation is that we have in V1 and V2, an RSR prime actually goes all the way to V3, suggesting that not only do we have junctional rhythm from injury or a transient injury to the His bundle, but we also have injury to the bundle as well, because it's not uncommon to nick the proximal portion of the right bundle, which is, of course, immediately adjacent to the His bundle. So if I saw this, I would be quite nervous about this patient. So on the one hand, you could say, well, he's not pre-excited anymore. And that's true. But on the other hand, he now has a bundle, which means there's been some injury to the AV node or His Purkinje system, and he's injunctional. And on this one beat, we have a suggestion that the pathway may still be there, because remember, when we're in junctional rhythm, we're not going to seem pre-excited because the impulse is coming from the His bundle, right? And I think that, Grace, your comment about retrograde P waves is likely correct, because if you look on these two, on this beat in particular at the T wave, and you compare it to these T waves, I think you would agree that there is no suggestion of this extra little inverted bump in the T wave. So I do think that, in fact, this is junctional rhythm following a botched ablation with retrograde one-to-one VA conduction. Now, you might say, well, if there's one-to-one VA conduction, I guess that means the AV node's okay because it's conducting retrograde. But what we don't know is if the patient is conducting retrograde through the accessory pathway. So we don't know if the node is working or it's the pathway. And in fact, unfortunately, the following day, this was the EKG that Dr. Flanagan sent me. And you can see that the patient was pre-excited again. I should mention, by the way, Dr. Flanagan is not an electrophysiologist and does not perform ablations. He just was kind enough to share this with us. So now, here's the problem. You don't know at this point if the patient's AV node is working, right? Because if you're pre-excited, you're going from the atrium to the ventricle through the accessory pathway and not through the AV node. And so there is actually, the only way to know if the node is okay would be to do another EP study. Now, if the patient started having orthodromic reentrant tachycardia again, Grace, what would that tell us about whether the AV node is working?
It would mean that the AV node is working, because either the retrograde or the antegrade pathway would have to be through the AV node to complete the pathway.
Right, that's right. In order to have tachycardia, you'd have to go from A to V through the AV node, and then, of course, back up the accessory pathway. So this is a nice example of an anteroseptal accessory pathway and what can sometimes happen. I wish I could tell you I've never seen this in my lab, but unfortunately, I've had this exact same problem in the past as well, though thankfully not too often. Okay, this is an interesting tracing of from a 3-year-old failed Fontan who is a status post takedown, and this is, I believe, was a heart rate trend that was obtained on postoperative day number 3. And wanted to ask Namrita Mozumdar, soon to be of Long Island. What do you think could be going on here? Now, I should tell you that unfortunately I don't have the time on the x-axis, but let's assume that this tracing represents, say, 6 hours total.
So initially the heart rate's around 100, 105.
Uh-huh.
And then you see a sudden increase to around 160.
Mm-hmm.
It stays there for a while and then it comes back down again.
Okay.
So
Any thoughts on what this would be based solely on a heart rate trend and no EKG at all?
there's a sudden onset and then an offset.
So what does that suggest about mechanism when there's sudden onset and offset? Is it automatic or reentrant?
Reentrant.
Correct. It's reentrant. And what else?
The heart rate, well, he's 3-year-old. It's pretty high for a 3-year-old. So I'd say it's like an orthodromic reentrant tachycardia.
Okay, so you're suggesting orthodromic reentry. It could be, but what do you think about a heart rate of 160 for a 3-year-old with orthodromic reentry? Is that a common heart rate for a patient who's 3, who's having orthodromic reentry?
That's true. Should probably be higher, like 200.
At least.
So maybe like atrial reentrant tachycardia.
Right. So, in other words, so when you're looking at or asked a question like this, the first thing you always want to ask yourself is just the demographics. And this is one of the reasons why I always tell people it's good to know EP for the boards, because EP questions on the boards generally are asking very straightforward questions because there's a perception that none of us know anything about EP, which could be true, although no one on this call will be able to say that. So if I just told you without looking at the tracing, I have a Fontan patient who has a heart rate of 160 and it suddenly started, without looking at anything, the first thought that should come to your mind is the patient could be an atrial flutter, right? Mm-hmm. It's also possible it could be some kind of atrial tachycardia, like an ectopic atrial tachycardia, but that doesn't usually start suddenly. It usually heats up and cools down. And when we look at this trend, we see it's a sudden onset and a sudden offset. And Fontan patients, of course, are notorious for having intra-atrial reentry. So when you see this type of a tracing, you could pretty much be certain that this is an example of intra-atrial reentrant tachycardia in a child with a Fontan. And if you've had a takedown of your Fontan, that means you've had probably at least 3 or 4 atriotomies. So it's a real rich environment for atrial reentry in somebody who has had a Fontan or a Fontan takedown. So this would be an example of atrial flutter or intra-atrial reentrant tachycardia on a heart rate trend. And, as we've said in the past, if you ever have a Fontan patient in your office who's beyond the age of 3 and has a heart rate much above 100, I would say it is, you have to scan the EKG very aggressively to convince yourself that it is truly sinus. I have seen some very senior pediatric cardiologists send a Fontan patient who's there for a routine visit home in atrial flutter, not recognizing that they were in 2-to-1 flutter. So you always want to look at the ventricular rate in your Fontan patients and make sure that if it's above 100, be darn sure that it's not some kind of atrial reentry. Particularly in an older Fontan, sort of say beyond the age of 8 to 10 years of age, it would be very unusual to see a heart rate much above 100. And certainly 160, unless they were in a stress test, pretty much guaranteed that it's going to be an arrhythmia of some sort, and usually intra-atrial reentry. Okay, is Perna on the line?
She's been deployed, and she's starting today.
She's been deployed. To those in the audience, that means deployed to treat our patients with COVID. So thank you very much, Perna. So I think then we'll go find Sanjeev Gupta, whose name I saw in the back there, back from deployment. Actually, the man whose place she took.
Wishing I was her right now.
I doubt it. Okay, you're always right, Sanjeev, so I'm not too worried. So this is a 3-week-old many years ago. This is a tracing from a thermographic fax machine. Most in the audience probably don't know what that is, but it doesn't matter. This is a heart rate of 255 in a 3-week-old who's in the emergency room. So why don't you tell me what you think here, sir?
All right, so the rate is about, sorry, it's a little hard to tell. I'm on my phone. So
Well, you can't really tell because the lines are so terrible, which is why I was kind enough to tell you that the heart rate is 255.
okay, thanks, sorry. So looking at, it's a regular narrow complex tachycardia. And looking at the P waves, I feel like I can see P waves. They look retrograde.
And why do you say that?
So looking at V1, after the QRSs, you can see P waves before the T.
I actually think that this might be the retrograde.
Oh, that whole thing.
I'm not 100% sure, but it's a very unusual looking T wave if this is the T wave, although it could be. I don't know. You could be right. Hard to know.
So then looking at the...
How would you know, by the way, Sanjeev? How would you know?
I mean, you could do an atrial electrogram if you have wires.
No, this patient's in the ER. I'm not going to, I like to play guess what I'm thinking. I'll stop that. Basically, when you see sinus rhythm, when we figure out what this is and fix it, you'll be able to look at the T waves in sinus rhythm and know what's a P and what's a T. So we really can't tell in this rhythm. But I agree with you. I think there is a retrograde P wave seen in somewhere buried in that T wave.
And then, so again, the intervals are probably hard to tell, but I would call this a long RP tachycardia because the P wave looks pretty far away from the preceding R.
And when you say long, you mean an RP interval greater than 70 milliseconds. Is that right?
Yeah, and also, I mean, I guess it looks longer than the PR, but you could argue that it looks kind of about the same, I guess. If the big negative deflection after V1 is the P wave, then the RP would be close to equal to the PR, but it is longer than 70 milliseconds for sure.
And what is special about 70 milliseconds?
So it kind of divides up like AVNRT versus AVRT in a lot of cases.
That's exactly right, yes. So in AVNRT or typical AVNRT, the R to P interval should be less than 70 milliseconds. And in ORT or orthodromic reentrant tachycardia, or as you refer to it, AVRT, AV reciprocating tachycardia, typically the R to P interval is longer than 70 milliseconds. And so the general rule of thumb is if you can obviously and easily see retrograde P waves, it's likely that the RP interval is greater than 70 milliseconds. And is this heart rate consistent in a 3-week-old with ORT or AVRT?
Yeah, it is.
So this is most likely AVRT, right? And so what are you going to do about it?
So, I mean, you could try, for now, you could try adenosine.
Okay, that's a good one. That would probably work. What else could you do? Let's say you're having trouble getting IV access.
You could try vagal maneuvers.
Right, so what vagal maneuvers would you try in an infant?
You could do ice to the face. I saw Dr. Srivastava one time gag the patient, and that was the only thing that worked. You could try use a thermometer and do like rectal stimulation.
Right. What about eyeball pressure? Would you do that?
Yeah, ice to the face. I guess you could do that.
Ice to the face, yes, but eyeball pressure, no. I mean, one of the more common ones was doing that, but that causes detached retinas and things. And also, carotid massage has fallen out of favor because you can crush your baroreceptor. So should not ever do that. But yeah, ice to the face, rectal stimulation. Not sure I would personally stick something down someone's throat and gag them. But I'm sure it works. And I see here that, can you hear me, by the way?
Yeah.
Yeah, okay, sorry. Dr. Raymond Morales is asking, how do I feel about pressing on the stomach for 4 seconds to force the child to Valsalva in anger? I would say if it works, it sounds great. Anyway, okay, so you've broken the tachycardia. The child is in the emergency department and is tachypnic and is in sinus rhythm at like 180, 190. So what do you want to do now? So you're in normal rhythm.
I would do an echo to make sure that the function is not terribly down, and that's why the patient's in sinus tach to maintain output.
That's correct. So roughly how long would a child of this age have to be in ORT to develop a tachycardia-induced cardiomyopathy?
I think generally about like as short as 24 hours.
Yeah, that's right. And every once in a rare while, I would say, you know, it depends on the size of your hospital, but roughly every 1 to 3 years, a child walks into the emergency room like this and has a very bad tachycardia-induced cardiomyopathy, can be actually very sick because the family was unaware that the child had this problem and therefore were unaware that it was going on and allowed it to go on longer than we would have liked. So let's say the function is normal. You're in the emergency room. You have a 3-week-old is now in sinus rhythm, is not pre-excited. What would you normally do for this type of patient?
If they're still in sinus tach, I would admit them and just kind of make sure that put them on telemetry and make sure that the heart rate trends down, you know, within a couple hours. And then number 2, make sure that they're not going into it very frequently.
And would you treat this?
Yeah, I would.
And what would be your preferred treatment?
If they've shown that they're not pre-excited, you could use digoxin. You could
Okay.
also use
Very old school, but effective sometimes.
I guess you could use a beta blocker.
Yeah, usually what beta blocker would you normally use in an infant?
Not sure, I'd be guessing.
Normally we would use propranolol in an infant. Why? Because it comes as a pre-made solution that's manufactured that way, and it's got a very long track record of safety in small infants. Typically the dose is 1 to 3 milligrams per kilogram per day, and although formally it should be given Q6, practically most practitioners dose at Q8 because of the difficulties in remembering to dose something every 6 hours. So, so that's usually what we would do. And if the tachycardia were more difficult, we could go to higher end medication dosing. Well, I have 1 or 2 more slides, but we're closing in on the 50-minute mark, and I think we should probably move forward and call it a day for the conference. Thank you for joining. And by the way, in the next week or 2, Dr. Ed Walsh has graciously agreed to join us for EP conference. I don't know when it's going to start, but this will be a dual run conference with me and Ed at some point in the next week or 2. So I'll send out a message on PD Heart if people are interested to join. I don't know if Dr. Walsh is up this early, but if he is, then we'll try to do it together. So everybody have a great week. See you next week.
Great, thank you.
Thank you.